My name is Jackie Rapat. I'm the Associate Dean of Research for the College of Rehab Sciences, for those of you who don't know me. So welcome to our Illuminate session. Today, our Illuminate sessions are a monthly series where we highlight research and researchers, both local, national, international, that have topics and areas that are of interest to us, and really to hope to develop some further conversations and dialogue about some of these emerging areas. So today I'm delighted to have Rosalie Wang join us. I'm going to start with acknowledging that the University of Manitoba campuses are on Treaty 1 territory, which are the ancestral and original lands of the Anishinaabe, the Cree, the Ojibwe, Dakota, and Dene people, and the homeland of the Métis Nation, and that our water is sourced from Shoal Lake 40 First Nations. We respect the treaties that were made on the lands and acknowledge the lasting impacts of colonialism and systemic racism in the past, and that continue into the present on Indigenous people and in communities. I'm going to introduce Rosalie now. I'm sorry, everybody's been ill and I'm still suffering from not having a great voice. But as I mentioned, we're thrilled to have Rosalie join us today, and she is known to some of us around here, so it's great to have her in virtual person. So Dr. Rosalie Wang is an associate professor in Department of Occupational Science and Occupational Therapy at the University of Toronto. Her research focuses on technology-based interventions to support older adults' daily activity participation and social inclusion, and upper limb functional recovery in people following stroke. She has an interest in methodological approaches for development, evaluation, and implementation of technology-based interventions and mixed methods research. She has also co-led a national project on enhancing equitable access to assistive technologies. So it's my pleasure to introduce Rosalie and to turn the camera over to her for her presentation. Thanks, Rosalie.
Excellent. Thank you so much. I'm absolutely thrilled to be here. And so thank you so much for the invitation. And I'm going to start sharing my screen now. I'm really excited to be talking about this topic, looking at sort of merging of two areas that I'm really interested in. So robotics and stroke rehabilitation, but also some of the methodological concerns that we might have related to implementation, or looking at the kind of evidence that we're generating. So, you know, I'm asking the question, the lack of compelling evidence for robotics and rehabilitation, is it time to cut our losses? So hopefully at the end of this presentation, you'll take away several things related to methodologies that we use in our evaluation and development of technologies, but also sort of a big picture overview of robotics and stroke rehabilitation. So I am familiar with a few of the folks on the call, but I'm just out of curiosity, thinking about who might be a practicing clinician versus a researcher. I don't know if there's any. Okay, I don't have a chat set up, but that's okay. Maybe we can have a look at that afterwards when we have a bit of time for discussion, hopefully. So. I would also like to start off with the land acknowledgement. So I am based in Toronto, and so we acknowledge the land that we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So first of all, just a couple of objectives here. Just, you know, if you want the sort of short answer to the question, is it time to cut our losses? I'm going to say no. And so that's the short answer, but we'll walk through a few different areas to really dig in to the topic. So I am going to dive into why I don't think it's time to cut our losses. I will discuss based on how we currently conduct our development of robotic interventions and how we try to implement the new technologies and try to illustrate why we need to reconsider how we're generating our research evidence and what might be most meaningful for development and evaluation. And I'll also present for your consideration a framework that we've created as an alternative to enhance the methodologies that we're applying to better generate evidence that is more timely and more meaningful for technology-based interventions, including robotics for rehab after stroke, and looking at approaches that we might use to support the integration of interventions into practice. So after I gave you the answer, hopefully you won't leave the presentation. So anyway, all right. So looking at the current status of stroke rehab for the upper limb specifically. So approximately 75% of stroke survivors have upper limb deficits, and 5 to 20% fully recover within 6 months. And so those numbers are not super encouraging. And this is also in the context of Canadian healthcare. Most of the therapy happens within the first 6 months post-stroke, and there is significant disparity in access in terms of rehabilitation services. So all across the continuum of care, inpatient, outpatient, community-based, and home-based. And of course, lots of different reasons for that. We won't be able to get into all of those details, but that is the situation where we're at. And there's also a lack of outpatient and community-based rehab targeting the folks who have chronic um, problems after they've had a stroke. And of course, ongoing economic pressures within our health and social care system really add to the lack of services and the lack of access. So for stroke rehab, for upper limb rehab after stroke, therapy is determined to be and needs to be meaningful, engaging, progressively adapted, intensive, and task-specific and goal-oriented to be able to promote limb function recovery and use of the limb in daily activities. And so these are from clinical best practice, the evidence-based practice guidelines for Canada. And what we also do know from the research is that people with chronic stroke, so over 6 months post-stroke, also benefit from ongoing intensive therapy for motor and functional gains. And so these gains continue to happen over time. And so even though there is a critical window that we're often looking at in terms of intense therapy after stroke, we do know that this does carry on, and people do need the support in order to maintain the gains that they've developed after their acute rehab, but also to be able to maintain and continue their therapy for additional recovery gains. So some of the characteristics of stroke rehabilitation, it is repetitive and labor intensive, which makes it difficult for both therapists and patients. Patients get limited one-to-one therapy time, and that does significantly impact the way that they're able to improve and recover. There are insufficient therapy doses, and so that is known from the research that we do not provide the sufficient frequency of sessions, intensity of movement repetitions, duration of interventions, and also the timing of delivery is not entirely clear, but also that we should be providing it at a specific point in time in the recovery process. And we also know that there is a lack of quantitative measures. We have a lot of clinical measures, but either they're not consistently used or we don't have a good way of being able to quantify what they are. And also in the context of home rehab, it's often self-directed, and people are not necessarily monitored very closely. So people have homework or home-based therapy that they're asked to conduct on their own, potentially with the support of their families, but there is poor adherence to a lot of these programs. And you can see from some of the studies listed there, 65% adherence to at least some part of their therapy program that's recommended at home, or another study said up to 70% is non-adherent. So those are some of the difficulties within the context of ongoing stroke rehabilitation. So what is the need then? We do need to continue to look for approaches that can augment current one-to-one therapy that is provided by therapists, so to increase the therapy dose and also to improve patient outcomes. And we also need to look at approaches that can enhance the efficiency of therapy delivery and the accessibility of therapy for people in different settings and for more people. And so we know, geographically there are complications with having specialized stroke care in rural environments or remote environments, for example, and accessibility of therapy for people with different socioeconomic backgrounds as well. So lots of sort of big global concerns there. And so what is the premise really for robotics then? The idea around robotics is that it can be used to deliver high dose therapy that's required for motor recovery. So high intensity, high repetition practice. And so this is backed up by some of the literature. So a very important study by Lang et al. In 2016 found that less than 100 active movements per session did not show improvements in upper limb recovery. And in a typical session of therapy with therapists, it's about 32 movement repetitions per session. And what they found with the robotics applications is that robotic upper limb therapy can provide up to 300 repetitions per session. So that's quite a big difference. And this is really sort of the main premise of why robotics is something that is being pursued. So what are some of the other value added elements of robotic therapy? Again, as we mentioned, it has a potential to increase high intensity repetitive therapy, and that is particularly compelling if we look at increasing access of the therapy without ongoing therapist supervision. So the opportunities that might be provided with adaptive and intelligent systems that can monitor and augment and modify the therapy as the patient is using the system is really, really interesting, and potentially so that therapists don't always have to be there. And again, with that notion is if we have portable and safe systems for use at home, that provides additional opportunities for patients to be able to conduct their practice with some of the benefits of, for example, improving therapy adherence. So if there are motivating, engaging games and interfaces, and that also provide encouragement and real-time feedback, patients might be more inclined to continue to participate in their therapy programs. On the other side, for therapists, some of the potential value added elements are it focuses less on repetitive activities during active treatment time so that therapists are able to focus more on functional activity training and, very importantly, community integration. And again, looking at quantifying performance changes, so looking at outcome measurement, use of robotics may better quantify performance changes. And some of these areas are being actively looked at as well. So there are many different robotic systems in various stages of development, and you can see some of the examples here. There are some that are also commercially available, and unfortunately in Canada, there are very few that are integrated into practice, and that is particularly associated with the high cost of what they are in terms of the therapies that they might be able to deliver. And so you can see from the images here that there are various combinations of shoulder, arm, and hand-based robots, or different functions that they can assist with improving motor recovery of. And so some are end effector robots and some are exoskeleton robots. So you can sort of have a look to see what they are focusing on. And again, each of the different systems have different form factors and different functionalities associated with it. And so there are different ways that they can execute their sort of therapeutic benefits. And so at this point, I'd like to sort of just reaffirm that use of robotics in rehab after stroke is considered a complex intervention. And so we do have the technology that is as part of the intervention. That's one element of it. But we also do need clinical practices in order to support the delivery of robotic therapy. And so the all-important therapist element of it. And that is also critically needed. And there's also a component of education and training that's also part of it. So training for the patients and their families, but also for the therapists to be able to appropriately and adequately deliver the therapy using the robotic technologies. And of course, with stroke rehab and other types of rehab for chronic conditions, social supports are also very important to be able to support individuals in different environments, particularly in the home, to maintain their therapy. And I'll come back to the complex interventions discussion a little bit later as well. So looking at the current evidence, what do we have in terms of efficacy and effectiveness? So robotic therapy for the upper limb has been in development for probably about 30 years now. And just zoning in on the research that has been conducted sort of around the last several years. So I did a quick search looking at the research from 2016 to 2022, and I found 11 systematic reviews of different areas, different types of robots, but just sort of looking at it from a really, really big picture perspective. What is available out there? And for anybody who is looking for a PhD project or any project that's related to this area of work, I think I didn't find an overview of reviews or an umbrella review. So that's a really interesting area to get into if anybody is looking for something to do, because everybody is. Not really, but yes. So there are 11 systematic reviews that I found. And again, just, a really, really quick overview of what is there. And again, I'm not claiming to know all of the nitty-gritty details of all of these studies or all of these systematic reviews, because there's a lot of nuance in the different research questions for the reviews and the inclusion-exclusion criteria, things like that. But overall, 4 out of those 7 studies found mostly positive findings. And then there were the remainder that had mixed or neutral findings. So neutral being comparable, not that much different to clinical practice at the moment, or did find some positives, but didn't find anything significant in terms of other outcomes. So the reviews are basically saying some positive and some neutral or mixed. And just a quick, again, high-level summary of these studies. Each review included between 11 to 55 studies, and most of them were randomized control trials. 10 out of 11 focused on post-stroke rehab. And many of the reviews indicated that the studies ranged from high to low quality. And some of the other things that came out from this sort of body of evidence is that there is a need to explore other benefits that are beyond effectiveness. And so the labor intensiveness of delivering the therapy, the human resources costs related to it, and patient engagement and patient adherence are also important elements to be examined. And just to give you an example of the kind of review that was included, this example from Merholz from 2018, the systematic review looking at 45 high quality studies according to their criteria. So they were looking at electromechanical or robot assisted arm training post-stroke. And this is, I think, version 4 of their Cochrane review. And so they've been working on this particular review for many, many years now. And I think 2018 was the most recent update. So they found that use of these technologies did improve daily activity performance, which is fantastic. It did improve arm function and arm muscle strength, and it was safe to use. And actually the safety part was over the totality of the studies, safety didn't seem to be a major concern that was highlighted, so that's also great news. But a lot of precautions in terms of the interpretation of these sort of overall findings. Some of the things that they had indicated in this review was that the trials varied in training intensity and duration and amount. And the treatment types varied as well. So lots of different nuances in the actual treatment, the type of robotic therapy or functionality varied. And of course, participant characteristics were variable and the outcome measures varied as well. So lots and lots of caveats in terms of this systematic review. But when Merholz and colleagues as well in 2020 looked at a meta-analysis of 55 randomized control trials. They did find that with robot-assisted arm training, looking specifically at daily activity and hand-arm function and strength, it was not, the use of robotics was not statistically better than conventional therapy. And so in this, systematic or this meta-analysis, that was their conclusion. And so systematic reviews, we know, presents a specific kind of evidence on intervention effectiveness. And again, lots and lots of questions about implementation remain. And so it does cast an interesting sort of perspective on things where if you have something that is potentially not statistically better than conventional therapy, and plus we have a lot of implementation considerations and questions, unknowns, and feasibility challenges, it does not sort of create a compelling sort of argument for let's implement robotic therapy right now because it is so wonderful. So what are some of the unknowns then of all of these sort of different types of robotic interventions and the mode of therapy that we're proposing? So we don't know exactly which treatment modalities. These are all sort of questions that still remain to be discovered in research. So when we talk about modalities, it's talking about the specific treatment mechanisms that they're offering. So different control strategies and things like that, or sorry, modalities. I'm skipping ahead here, looking at things like whether we would like an exoskeleton or an end effector robot, and which type of, how it's actually delivering the therapy that it's proposed to deliver. And other questions related to for which patients and for when is an appropriate time to start implementing robotic therapy. Again, questions about intensity and duration of treatment. These are bigger questions beyond sort of robotic interventions on their own. The idea of looking at what the dose is a big question still in stroke rehab. And as I mentioned, what control strategies and feedback approaches. And so do we look at active assist, passive assist, and the timing of the feedback, the kind of feedback, do we incorporate audio, visual, haptic? All of these things are still sort of questions to be uncovered, or answers that need to be uncovered. And one of the big questions for me as an occupational therapist is how can we transfer some of the motor recovery gains to functional performance in daily life? And also, how do we tailor our treatment programs to best meet the needs of our clients? And so, various combinations of robotic therapy. Do we add homework? Do we add different kinds of, goal goal targeted types of training? And is it all repetitive? Lots of different questions here. And is it cost effective? Always a big, big question, because we are living in a publicly funded system for the most part. What are, the cost effectiveness elements of that? And so as clinicians, what do we do with all of this information? It is extremely complex to kind of tease through. And then of course, how do we make decisions about whether or not to use these interventions then, and how to use them in interventions with our clients and for our own settings. And so we have a whole body of literature, but it doesn't necessarily tell us a lot about, can I translate this into my practice with my patients? So again, there are elements of clinical practice that we had stressed before, being a complex intervention. There are gaps between the evidence and its translation to practice. And so the lack of clinical practice guidelines for robotics in stroke rehab has been something that was identified. And it's unclear about which patients might benefit most from different types of robotic therapies. And again, uncertainty about the timing of therapy using robotics. And I think somewhat positive news from a systematic review of the economic costs. As I mentioned before, the cost of robotic systems is often very prohibitive for clinics and for hospital systems to be able to integrate into their sort of repertoire of different intervention types. And so the economics is very critical in terms of being able to integrate something into practice. And so I guess the great news from this systematic review is that it is now looking like for some of these newer studies, some of the outcomes that they're looking at, they looked at robotics versus conventional dose match therapy. And so they looked at cost per patient session and cost per patient in the hospital setting. And they found that the cost outcome in 4 of the 5 studies that they identified, so bearing in mind that only 5 studies were ultimately included in this analysis here, the robotic interventions actually seem to be better in terms of cost benefit. And so that is extremely encouraging. And again, you'd have to look in detail into the individual studies themselves to sort of look at what the nuances are in those particular studies. But they did sort of see a trend that most of the cost benefits potentially were coming from people who have more severe degrees of impairment after stroke. So some promising evidence there. So what are some of the implementation barriers then? Again, there is still a lack of convincing clinical evidence. So if we look at the paradigm of evidence right now, looking at the randomized control trials and the systematic reviews, evidence is not really that convincing, but promising. And there's a huge gap in knowledge in terms of how we best use these robotic technologies in practice. And there is still an element of technology complexity. So high usability, it still needs to have systems that are highly usable for patients and therapists, and sort of minimizing if you're in a inpatient rehab setting or an outpatient rehab setting and you have patients coming through, the time for setup and the time for sort of programming what might be needed for the individual, that still takes up a lot of time. And a lot of therapists may say that it would be wonderful if we didn't have to do all of these things. Some things are more automated. They don't want to take away active treatment time from their patients. And again, robotic systems are still high cost for initial purchase, and maintenance and training are often elements that are associated with resource use. So, okay, so what do we make of all of these? Make of all of this? So I'm going to be switching gears a little bit now and introducing our FASTER framework. So the framework for accelerated systematic technology-based intervention development and evaluation. It is a complete mouthful, so that's why we are calling it FASTER. So looking at all of the evidence that is available, what if we say that we need to change up how we look at evidence and how we generate evidence? So thinking about what we found from all of this literature that we have so far, what it seems to me is that the research approaches that we're using or we're actually trying to tackle a very narrow stream of evidence, and whether or not something works in very defined circumstances. And so when we think about the evidence on efficacy and effectiveness, it is a very narrow stream. And we're not tackling the broader questions of feasibility, whether things will be accepted, how it can be integrated into practice in real world settings, and how we might be able to reasonably resource these, so provide funding for these treatments. And so there is often a significant drive to develop something and to push it to large multi-site studies as soon as we possibly can, to look at its effectiveness as sort of the pinnacle, the definitive sort of kind of evidence that we need. But once it's determined to be effective, it's assumed that it would be adopted and accepted because it has clinical effectiveness. But we know that that's not how things work at all. And so I want us to reconsider and potentially change up how we look at evidence generation with these technology-based interventions like rehabilitation robotics, to be able to get at the evidence that we need that is comprehensive and focuses on patients and therapists, and really to support technology transfer and integration into practice. And so In this next part, I'm going to be providing some background information and then critically discuss the methodologies for evidence generation related to technology-based interventions. And so we'll explore approaches and opportunities to enhance evidence generation to really try to support integration of these technologies into practice. So what I'm proposing is that we need a fundamental shift in how we generate evidence in technology-based interventions in disability and rehabilitation. And so this is in order to reconsider what is defined as high quality evidence and to support the integration of these technologies into practice, and particularly when we have technology that is rapidly evolving. So just to provide sort of the quick backdrop of the current approaches. So evidence-based practice, as we all learn in school and that we all try to do, is clinical reasoning integrated with research evidence, the best available evidence, patient or client values and preferences, and clinician experience. So this is well documented from many years ago, something that we learn in school. There's also a hierarchy of evidence, and we've seen all of the different images of what these are, with the gold standard or the criterion standard as the randomized control trial, and the systematic reviews and meta-analyses of RCTs as really sort of the area where you want to get to in order to develop your clinical practice guidelines and all of those things. So that is sort of the framework that we're all sort of surrounded by in terms of hierarchies of evidence and where we want to eventually get to in terms of the evaluation of our interventions. And clinical trials, also, I think very familiar to all of you, is any research study that prospectively assigns human participants or groups of humans to one or more health-related interventions to evaluate the effects on health outcomes. And this really is trying to produce evidence on whether an intervention works within certain conditions, with common applications that are often in pharmaceuticals, medical devices, and different medical surgical procedures. And it has definitely been evolved around sort of medicine, pharmaceuticals, and we adopt these in our disability, we adopt these practices in our disability and rehabilitation research. And it is problematic, and I'll go through some of the reasons why. And they typically have 4 phases, and they're outlined by the World Health Organization and other organizations as well. So phases 1 to 4 in sort of the common language of clinical trials. So what I'm going to say, though, is that there are lots of issues with the current approaches that we are using. So this paradigm with the hierarchy of evidence and with clinical trials practices, they are often inappropriate, unfeasible, and too slow for technology-based interventions. And so in the paper that we have published in 2021, documenting the FASTER framework, we outlined a series of issues that are specific to this integration or trying to adopt these kinds of practices within technology-based interventions for disability and rehabilitation. And so oftentimes some of our interventions in disability and rehabilitation have obvious and observable benefits so that we're not necessarily needing to do a randomized control trial with blinding, for example. The findings from some of these studies, particularly with randomized control trials where we have to sort of try to limit biases and hone in on a particular range of the population, or restrict inclusion criteria to minimize confounders. These findings often have limited generalizability to real world context. So a clinician picking up a research article looking at an intervention may not be able to readily translate that into their own practice because of the restrictions that are placed on the studies themselves. And often with these types of trials, we have an over-reliance on group means and overlooking valuable individual responses or characteristics that might influence the outcomes. And so as therapists, we often are looking at, the outliers, the people who are, improving or doing really well. But if you then sort of put it into, a group and looking at the means, we kind of lose that nuance of information. And so we want to be able to see who is improving with a particular intervention and who's not, and to be able to help to identify some of those factors that help us to improve for our individual patients. And heterogeneity in our rehab populations is just a reality. Lots and lots of different ways that conditions manifest or present themselves, and lots of different factors that influence. So, not just factors specifically related to the disability, but also related to environmental factors. And so populations are very heterogeneous, the people who we're working with. We're often not able to look at lifelong use, and this is particularly related to assistive technologies, and the sort of so lifelong use and impact are not always considered in some of these trials, because they want to be able to find efficacy within a short period of time to see. And monitoring somebody over 10 years in a randomized controlled trial is just not done. Cost and funding challenges are often a big issue in terms of multi-site, large-scale studies, and particularly with robotic technologies, we don't have sort of the resources necessarily to have a lot of systems to be deployed in order to do large-scale testing. And so those are extremely costly. And also finally, the necessity for efficiency and expediency to align with rapid technology advances. And so lots of changes happening in development. And so if you have a randomized controlled trial, multi-site, that's going to take 5 years, a lot will have changed within that time. So it's not able to keep up as well. So what we find then is that there's potentially a lot of wasted resources and opportunities in terms of working within this paradigm of randomized controlled trials as the gold standard, and clinical trials approaches that we currently have. And interventions may not be developed or translated to those who need them. And actually, I recently saw a title for a paper that basically was saying that our clinical trials killing our interventions. And I haven't had a chance to dive into that paper yet, but it was definitely a compelling title. So these are interesting sort of angles to kind of explore, because looking at whether or not our sort of fixation on these kinds of approaches are actually limiting what we might be able to have available for our patients and therapists and others who may benefit from it. So if we maintain this sort of approach, we often are trying to maintain unattainable standards of evidence. And so looking at the totality of rehab research and evidence of the interventions, we're often not able to get to the stage of being able to conduct a really, really controlled study, because real life is messy. Delivery of rehabilitation is also very messy. So we go back to the sort of the complex interventions kind of idea, where there's a lot of different elements at play. So some of the things that might result from this is also loss of solutions and opportunities at the detriment of our patients and clinicians. And there's going to be a persistent lack of clinical guidance for technology-based interventions, but also a perpetual lag in funding policies and practices if we sort of try to attain these kinds of standards that are in the sort of system that we're working in. So I won't go over this in a huge amount of detail because of time, but I wanted to just introduce what the FASTER framework looks like. And so, and you can, I'll have a list of references at the end. So if anybody is interested, they can dive a little bit deeper into it. So it is a 3 sort of phase process that is really, really iterative, that we're looking at focusing on development and progressive usability and feasibility evaluation and scaled evaluation and implementation. And we'll also talk about some of the principles around this as well. And even though it's sort of looks like a cycle. There are cycles within the cycle, so it's very, very iterative. And so we're not necessarily, going through things exactly in that process. And so we created this in order to be able to provide some guidance for technology developers, researchers, and clinicians and others who make use of evidence. It's a three-phase approach, as I mentioned, and it's informed by innovation design processes such as design thinking and complex interventions, development, evaluation, and implementation, which was something that was that I'd mentioned before. It started in the UK. And we also came up with some guiding principles that need to be consciously and proactively embedded throughout the development and evaluation processes. And we also provide some resources in terms of the selection of research methods and designs that align better with creating technology-based interventions and clinical practice evidence. So some of the features of FASTER, we are very much encouraging an iterative rapid intervention prototyping approach and engaging in iterative testing stakeholders, especially users, in small scale studies during all phases of the research and development process. And we are also encouraging active inclusion of heterogeneous groups of users during development and evaluation. So looking at a process where we're trying to enfold diversity within our group of individuals so that when we create an intervention, it has a greater opportunity to benefit people. And we're also supporting early deployment and scaled and replicated evaluation of interventions in real world environments. And so, coming out of the lab as quickly as possible to get feedback and to be able to test things out and get feedback to iteratively improve. So some of the guiding principles, user engagement, as I had talked about before, transdisciplinary and transsectoral working. So being able to incorporate a diversity of individuals who may be impacted by the intervention, but also individuals who, work in other sectors, who may be responsible for funding, who may be responsible for knowledge translation, commercialization. So really actively including industry and policymakers in this process because their input into this sort of domain is really, really important to, enhance feasibility, enhance usability, and ultimately being able to be successful in trying to get the technology out there. Ethical practices, we can spend weeks and weeks talking about this, but I'll leave it there. A lot of specific areas around that, not necessarily just research ethics, but the ethics of access and how we are creating our technologies. So, and also the final sort of principle that kind of envelops everything is looking at process evaluation and reporting to support transparency. And so that's really looking at things like how we're, sort of a meta view of how we're doing the research, are our design decisions and study design choices really reflective of a sort of process of critical thinking. So So just a sort of quickie view, blow up of some of the areas in each of the phases here. So yeah, different phases of development and some of the research methods that might be suitable in the different phases. And in this development phase, what I want to iterate is the importance of incorporating evidence and theory to inform your intervention development. It is something that I do see that's missing in a lot of development, sort of jumping from, we've created this awesome robot, and now we're going to test it in a randomized control trial. So all of the stuff in between is not always documented in the literature. And I think we need to be able to have that information out there to sort of evaluate, is this intervention grounded in current evidence of sort of motor control learning, motor control theory, and motor recovery, things like that. And is it theory driven in the sense that is it incorporating rehab readiness and all of those different kinds of elements within it? And so I think there does need to be a greater focus on the systematic and comprehensive development of interventions so that it could be evaluated with greater success. And so some of the things that might be really critical in this development stage is looking at, you know, process and outcomes modeling. So defining the ingredients of the intervention, looking at explanatory and logic models, being able to really understand why should our intervention even work, and being able to really detail that so that it is understandable. And if it doesn't work as we anticipate, what are some of the explanations for that? And again, being able to describe the proposed mechanisms of interventions and actions, and possibly kind of lead us to what are our targeted outcomes for our specific interventions. So phase 2 is progressive usability and feasibility evaluation, and again, a selection of potential research methods there. And phase 3, scaled evaluation and implementation. And again, another set of research methods that potentially would be appropriate. We are going through this super fast, and I hope that it would sort of entice you potentially to read our paper. I've been told that the paper itself is also very dense, and so it takes a little bit to get through, but hopefully you'll persist. Uh, but just kind of rounding out this part of the discussion, we include research methods and designs that are emphasizing diversity. So steering away from the ultimate trying to get to the randomized control trial stage, but really focusing on diverse methods that answer the questions we want to know, particularly about usability and feasibility, so that when we're doing our development and ultimately our evaluation, we're going to potentially have more success, that things will target the right outcomes. We are looking at it comprehensively so that there is a much bigger chance of success in the form of integration into practice. And we are emphasizing that no single research method or design is universally suitable and effective, and it really does need to match the study goals and the research questions and the maturity level of the intervention. And also that all methods and designs will have their strengths and weaknesses. And so we need to consider all of that when we interpret our findings. And something that's really important is that we want sort of a cumulative evidence base. And so it might be from different study designs or different ways of understanding the problem, but multiple and diverse studies can lend credibility and generalizability to the findings. And so we're not necessarily focusing just on, what does the randomized controlled trial say, but looking at the totality of the evidence that might be coming from, case studies or single subject studies or pre-post tests. If we have evidence that's pointing in one overall direction, that would be a strong evidence base. Okay, so these next 3 slides are just examples of some of the work that we've been doing, looking at incorporating some of these principles and ideas into our discussion, or sort of our generation of evidence. And so I had identified that there were some issues with the current approaches that we're taking. And so one issue was the findings have limited generalizability in real world contexts, but if we were to adopt the faster approach within these studies, so, for example, we've engaged early and ongoingly users within our processes, and we've included heterogeneous user groups within, our studies and development processes. And so these activities potentially would help in terms of the generalizability of our research findings, and hopefully it would help to support the use of these kinds of technologies. So we've incorporated, a systematic understanding of the intervention contexts. We've used iterative usability and feasibility evaluation with users in the real world, and we've tried to, get our studies in place in earlier stages of the development of the robotic technologies. And over-reliance on group means and overlooking valuable individual responses or characteristics. that might influence the outcomes. And so some of our other studies, we've looked at using diverse research methods at the earlier stages so that we are able to capture individualized data that we can report in case series types of studies. And really, these are really informative to broaden our understanding of how the interventions work within different user contexts. And finally, cost and funding challenges and the necessity for efficiency and expediency to align with rapid technology advances. We are really emphasizing the use of diverse research methods and designs so that we can incorporate also rapid iterative prototyping so that we don't spend a lot of time developing technologies that may not necessarily work. So we're testing at early stages so that we can correct and change course with our iterative prototyping and evaluation so that we potentially reduce research waste and enhance the expediency of our research. And of course, we have ongoing user engagement and diverse collaborations with different people from different sectors. So we're making sure that design decisions are grounded in what users would like, expect, and might need. So going back to the question of, is it time to cut our losses? Yeah, again, my answer is no. We still need innovation to augment therapy and enhance delivery and accessibility to improve patient and systems outcomes. And we refer back to the value added of robotics that we talked about in the earlier part of this discussion. And so we do need more innovation. And robotic technologies are evolving extremely quickly, and lots of opportunities are coming up to be able to leverage the technologies. And there is also a progressive movement towards low cost, high usability interventions. So something that gets me super excited these days is wearable therapy and assistance in the real world. And so again, being an occupational therapist, being able to have people embedded, immersed in their everyday lives, in the community, in their homes, having therapy in context, and having assistance in the real world, rather than in a clinic setting or having them go to a hospital in order to get therapy and not being able to translate that into their everyday experiences. So the notion of wearables really excites me. And it does also promote participation, integration into the community where people would like to be. And the idea of wearables that are discreet, that minimize stigma, are also really promising to be able to support inclusion. And so the days where we have massive medical looking devices where people don't want to be out in public, I think that is something that we're definitely changing course around. So that gets me super excited. And so the question of the lack of compelling evidence, the lack of compelling evidence is really restricted to the type of evidence within this paradigm that we're working within. And as I sort of outlined, we can definitely do better in terms of the kind of evidence that we're generating and how we're doing it. So expectations for the future, I hope that there will be more emphasis on engaging users and therapists in development and prioritizing usability in development. And so not necessarily just, techie folks or scientists with their heads down developing and creating something that they think is going to be perfect, but really trying to bring in the users and the therapists within that development process to make sure that even though their development might be technically awesome, but it's also really catered towards the people who are going to be ultimately using them and incorporating it into their lives. Um, I also hope that development research, and also in line with that, the publications would detail the evolution of an intervention. So we can see, whether it's theory driven, whether the mechanisms of action are intact, whether they're looking at logic models about explaining how their intervention is supposed to be working. I'd love to be able to see that in publications and valued highly in comparison to, the large scale effectiveness studies that we are often sort of seeking. And I also would love to see multiple domains of feasibility being looked at in the research as well and in development projects. So, looking at technical, clinical, and economic feasibility, and also some of the, common things related to research feasibility, as I've given a few examples here. So that is the end of my presentation. And so again, lots and lots of areas where I'm personally excited about. So again, I mentioned the wearables, but also this sort of, progressive shift in being able to enfold more and more stakeholders and collaborators into our research and development processes. So I sense a lot of excitement from individuals who are working clinically and in industry to be able to really come together with researchers to sort of enhance the work that we're doing, both in terms of getting at the right kind of evidence, but also being able to, provide a lot of training for clinicians to be able to deliver this therapy, but also working alongside industry to be able to get products out there that potentially would be benefiting a lot more people. And again, some of the other things that I'm excited about is this transition in terms of, as I see more and more papers being published around, our randomized control trials really are gold standard. And again, more more papers are being coming out that are saying that, no, actually, there are a lot of other dimensions of research that are often neglected that we really do need to kind of raise up because they're highly valuable. So. All right, just a quick acknowledgement to my FASTER Collective collaborators here. Yeah, thank you. So I don't think I've left any time for questions, but you can email me or I'll still be on the line if anybody is interested and available.
So thank you very much, Rosalie. That was fascinating. And you're so excited. I'm so excited that there's recognition, I think, of different ways of looking at evidence around this. And I think that's been, it's been really a challenge for so long for all of us to for exactly the reasons you outlined. So I really appreciate this framework. I would love to have a workshop on it. Honestly, I think that's maybe the next step. We need to get you to do a workshop for us. And I'm interested to see how it all translates, like to actually see it in the application of the framework and some examples too. So I look forward to looking at some of those publications. I'm going to officially close our Illuminate session because we are at 1 o'clock, but certainly, as you said, generously, if there's anyone who wanted to stick around and had a question or two, then I don't know if you have a few minutes, or we could set up another time too, if that doesn't work for you. But on behalf of the College of Rehab Sciences, thank you so much for this great presentation, and really made me, made I think all of us probably think differently, and that's really what's needed. So I really appreciate that. I see a comment in the chat too from Ed. Says thanks, Rosalie. Great, covered a lot of ideas. Gives us thought for future or further consideration, especially around the use of telerehab with robotics. So thank you. All right, I don't know if there's anyone who is still on the line. We've lost a few who probably have running off to 1 o'clock meetings, but if there's anyone who has a question for Rosalie and she's willing to stay for a few minutes, is that okay, Rosalie?
Yeah, sure. Yeah,
okay, yeah. Great. So anyone who wanted to ask anything or comment on anything? Yeah, no, thank you, Rosalie. I think it's such needed work, and it's exciting. I have a million questions. I'm just going to have to set up another time to just talk to you about that in terms of how the application of the framework. But I think it just is really speaking to so many challenges, as you point out, that we know are in place and just haven't had the ability or the thoughtfulness to be able to address before. So it's great.
Yeah, thank you so much for inviting me.
Yeah, fantastic. Okay, thanks everyone. And we'll sign off, but Rosalie, I will be in touch.
Okay, thank you.
Okay,
Bye.
thank you so much.
Bye.
Bye.
Bye.